All right, welcome everyone. Thank you all for joining us today. It is truly an honor and privilege for us to have one of my dearest mentors, Dr. Kristine Olson, here with us today to really talk to us about the optimization of collaboration between the chief wellness officer world with how important well-being is in the workplace and outside the workplace and so forth, and how we can intersect with our profession as occupational environmental medicine and occupational health professionals in general. And special thanks to Chris and Keith of Johns Hopkins ERC for co-sponsoring this with us as NECOM and MARCOM. And so without further ado, I'm going to go ahead and introduce our illustrious speaker, Dr. Kristine Olson. So to start with, I will mention that Dr. Olson is one of the nation's inaugural chief well-being officers and truly a thought leader in organizational, personal, and professional well-being in healthcare. She's a native of the Midwest in Minnesota, having obtained her medical degree from the University of Minnesota, followed by training in internal medicine and pediatrics at Yale New Haven Hospital, and as well as completed a fellowship in health services research and epidemiology at Cornell, with a focus on that organizational system science and professional well-being. And she did get 2 years of executive education at Yale School of Management and is also a Peace Corps volunteer with extensive global experience in that comparative healthcare systems and post-conflict zones, which is, of course, very pertinent in this day and age that we're living in. And she also has a diploma in tropical medicine and traveler's health from the United States Uniformed Services, and also has some experience in emergency preparedness. And even now, she's working with multiple organizations from the National Academy of Medicine to the American Medical Association and the Institute for Healthcare Improvement, and is involved with the American and international conferences on physician health and several other boards, including the Stanford-led Professional Wellbeing Academic Consortium. And so without further ado, please join me in welcoming Dr. Kristine Olson for this talk. And please be ready with questions as well, because I promise it's going to be a very thought-provoking discussion. Please take it away, Dr. Olson.
All right. Thank you, Dr. Santiago. Romero Santiago and I worked together at Yale, where he did his fellowship in occupational health, and he was such a key and important leader in our Clinician Wellness Council. And I consider him such a champion and leader in the wellness space and leading in occupational health. And it's been great to be adopted into that space through you. And I see Brian Bowman's here, who I also have had the pleasure to collaborate with and, befriend over the years too. So I feel amongst friends. So thank you for having me. And I hope we can have a really great, robust conversation. So I'm going to tee up some of what we talked about. Dr. Santiago and I talked about what would be relevant to this conversation, but we're really hoping that it will bring conversation at the end. So I hope those of you that are here can be here to participate in the recorded sessions so that you can represent those who couldn't be here because they're held up by their clinical activities. Okay, so I'm going to share my slides here. All right, so, okay, I got the thumbs up. So we're talking about optimizing collaboration and synergy between chief wellness officers and occupational health. And this is going to be part of our ongoing conversation. I'm going to start with what Dr. Santiago and I put together is thinking about what is the role and scope of a chief wellness officer and the ways that a chief wellness officer collaborates with the other stakeholders. And then what are the tools and roadmap for individuals to optimize collaboration between the CWO and occupational health. And you're gonna help me I'm gonna tell you ways that I know we can collaborate, and you're gonna tell me more ways we can collaborate. And we're also gonna talk about occupational health professionals as chief wellness officers. So you heard a little bit about my background already in the introduction, and I thought I would put this part because it's kind of a foundational thing for me that when I was my family has the values of if you have an education, you give back. If you have the privileges, you give back. My grandmother was a World War II vet and helped to make sure that women veterans had access to the VA Medical Center. For example, she always stayed civically involved. She worked with the senator's office to help interview people who were service oriented to the country to go to military schools and things like that. So when I went to the Peace Corps, that was a pivotal moment because you're completely removed from your own culture and all of the context, and you're put in the middle of Southern Africa. And I think this was the eye opener of how history, governments, power politics, policies, and things like that, how they shape the way people live and thrive and how people want to live and thrive and what's in their latitude of control and not in their latitude of control, and what makes people so resilient and helps them to thrive. So that when I went on to do other international work, I also saw patterns. And when I started in medicine, I also was oriented toward how do we govern medicine? What's health policy? How did things get this way? How are we able to thrive in our mission? Is our performance in our mission optimized? So this time for me of being cross-cultural around the world and seeing history and policies and thriving and how we live was very helpful. And when I came back to medical school, I also did a lot of work in looking at the difference between what helps people uh, thrive, be stressed and distressed, and what made people resilient and thriving. And I continued to look at system science. So Dr. Donabedian is one of the pioneers and founding fathers of health services research. I feel like I really follow in his line because he, in the beginning, in 1966, you have Medicare and Medicaid come into existence. And this is the first time we start having conversations about who decides what's good medicine, what's quality, what gets paid for, who makes those decisions. And so he starts doing health services research, and then I kind of follow the line of scholars from that point, from his writing on, and in my fellowship had the chance to read all of that literature. And he has us oriented to what goes on here. What is our why? Why are we doing this? And when we think about in healthcare, we kind of adopt the now quadruple aim of making sure that people have affordable access to safe, high quality care and a satisfying, exceptional patient experience that's delivered by high performing physicians who are doing well, or clinicians. And then also, I do like, because I think this is true, that Dr. Donabedian said the secret to quality is love. It may sound hokey, but I actually think it's true. So keep it in mind, because when you think of anyone who's delivering services to you, if they care about you, right, they're going to be attentive to the details. So when we think about why do we care? Why does this matter? And let me just say, as we go into this particular part of the conversation, think of physicians as whatever population that you're caring for. Because I know in occupational health, you might be caring for people in healthcare, or you might be caring for people at the post office, or at the automakers, or other industries. So just think of this as an example of a way to kind of tee up our thoughts and our conversation. And also in healthcare, there are a lot of different people, and the questions are different. If you're talking about food service, environmental services, transport, nursing, physicians, pharmacy, all of those are, it's the same kind of approach, but there are nuances that you have to not assume that you know too much without asking them. And I think that's the general principle in all of this work, is that people need to have a voice and be able to educate us of why they are able to do their work well and love it, or why they aren't. So when we look at why this matters, and we look at Dr. Tate Shanafeld does these triennial surveys to look at what's the state of affairs for physician wellness. You think about your population that you're looking at. So he looked at physician wellness. He saw burnout just before healthcare gets implemented. Healthcare gets implemented. Wellness becomes a top priority. We start making progress. The pandemic hits. We're all called to the historic event. And then we go into a lot of political and social um, turmoil, as well as pent-up demands, the cost of the pandemic. It went on longer, for example, and then we hit a real record high of burnout. And then now it's coming down again, so that's good news. But you see in the general population how steady it is, which gives you the indication that this is something going on in the healthcare industry. It's not the whole population. This is up and down with the healthcare industry. And if you look at the right side, you'll also see all of the different specialties. You'll see that it's going up and down with all those specialties across the country too. So you can see that it's in our industry, that this is ours to own. And then early on in this work, when you start trying to address wellness and convince people that it's an issue, people might think, oh, those are just entitled, complaining doctors. Get rid of them. They're toxic. But then you show the numbers that it's over half of your total physician population, that it's clearly dynamic across the industry, not in the general population, across the specialties, temporally related to people entering medicine and clinical work, dose related to their FTE as far as their clinical work, and that it's more amenable to organizational interventions than individual ones. Then they start seeing like, oh, I guess we're going to have to pay attention to this and do something about this. It's ours to own. So a little bit of what's going on for context is that, I mentioned 1966, we get government payers, Medicare, Medicaid, and we start to have the question of, do physicians and their patients get to decide what is quality and what's going to be paid for, what's going to be done? Or the payers are going to say yes or no. You can or cannot do that. That is or isn't quality. And is it going to be overridden? Is it going to be collaborative? This whole health services science field really takes off. And then as you coming into the 90s, you're also looking at physicians being, physicians used to have really full control, and people called it paternalism because they could kind of dictate everything and the patients didn't even question. So then the patient satisfaction movement, it was really patient autonomy that became patient satisfaction and patient-centeredness. And then in the 90s, you also have the Dartmouth Atlas and showing variation in care, crossing the chasm to Air is Human, where you start to have the quality movement, where we start to try to get rid of variations in care and having more streamlined set things for care. And you can see that over these years, this image here depicts the rate of rise of physician population here at the bottom, that little line, that little sliver. And people say that that does not even keep up with the growing population in the United States. And then you see the rate of rise of administrators. And this is indicative of just how administratively complex that healthcare has become. And people say that physicians will say, we're strangling in red tape. We feel like a hamster on a wheel. We have to do more and shorter visits. And they start giving up their private practices to go into employment models because you just had to work so hard to hire more and more people for the administrative complexity and the overhead costs of running a practice. So they were moving into hospitals. This was before healthcare reform. And then with healthcare reform, you can see that part of the strategy was to also hire physicians into these systems, and that they also became regional systems. So down here at the bottom, you can see physician ownership going down by the decade here at 76 in 1980s to 44% in 2020, according to the AMA. And then another independent group showed that only 26% of physicians are independent now, that many of them are hospital employed, but a growing number, like a quarter, are now employed by corporations, including private equity. So why does this context matter? Because what anyone in any field wants to do is to do a great job and be proud of their work. So they want to be able to have some latitude of control in the practice management and clinical decision making, of which they're extensively trained and for which they have high stakes, complex decision making. And they want to be in service to their patient to get a high quality result. And then they also want to have a chance to rest and recharge for the next day so they can do it long term. And so when you think about the context of what does it take to really function well, you have to have great relationships with leaders and be value aligned. You have to have teamwork with your allied health professionals. That is teamwork and task work. You think of task work, your relationship with the EHR and other things, as well as the teamwork with people. You want to feel like you belong there with your colleagues and that you fit in. And then you want a sense of fairness and justice with reciprocity and reciprocation with the patient. You want them to say, hey, you did a great job, doc. I'm going to do what you said. I'm going to follow your instructions and I'm going to follow up, and you're going to have that kind of relationship. So when you think about what makes them satisfied, it's really being able to function in service to their patient to get that really high quality result. So sometimes people get nervous about, wait a second, physician autonomy or physician voice and agency. But I would say it's nothing to be afraid of at all. It's actually a treasure trove of information to help your organization work really well, to find out how can we be even better. And if you have a good system in place through your clinician, through your chief wellness officer office, for example, you can have an orderly way to be able to communicate to people how you're going about systematically to improve their professional experience so that they can have this kind of experience. Because you want to show how you're going to be a steward of the resources in a proper way. So when you think about not having as much control as physicians used to have when they had complete control before 1966, for example. And there also wasn't as complex with the number of technologies and pharmaceuticals and things that were available. It was also simpler then. You think about, why does this matter? So when you feel like you don't have voice or agency or latitude of control and you can't accomplish that, you feel hindrances, you feel obstacles. And here I'm thinking of the conservation of resource theory from, I think it was the 80s, Hopful. But you combine a number of things on thriving. If you go to this top right quadrant and you think of, this is where you want to be, you want to thrive, whether you're thinking about ikigai and like, oh, my what the world needs is what I'm good at, what I'm skilled at, what I can make money from, and I can do that and I feel great. It gives me meaning in life. Or you think about the PERMA model of feeling positive and engaged and absorbed and in the flow. You lose track of time, and you're in relationship with your people, and you have meaning and purpose and your sense of accomplishment and of vitality. I mean, you really want to remove obstacles so that your efforts, that you enjoy your challenges. Your challenges are those that are growing you personally and professionally, and also growing your organization, and you're growing the pie, and there's more pie to go around. You don't want to feel like everything that you feel you need to do for your high stakes job is kind of bumping your head up against the wall, and you're getting depleted. And as you get depleted and depleted and depleted, you feel like I have to remove myself from this situation because it's depleting me. You know, as you remove these obstacles, people can not be depleted by work, feel satisfied at work, and get to the point where they're really thriving. And you want to also watch out for overdoing it. If they're like, you're overdoing it and we never see you at home, and um, kids don't even know what you look like, then you might want to also think about if you want to come back, recalibrate. All right, so now you have those depleted people, and actually we're going to go in the next slide and talk about what depleted people do. Actually, let's do that first and come back to this one. So when people are depleted, they may physically feel like they need to remove themselves from the depleting situation. So they may retire early, reduce their work hours, reroute into other jobs. They may reroute into non-clinical work, administrative work, research work, some go to industry. They may restrict their scope of practice. OBGYNs may decide, I'm not going to do obstetrics anymore. I'm not going to do overnight call. I'm not going to do the high risk stuff. It makes it harder to do that. They may relocate and not stay at your organization. Physically, they may resist the work where you're going to have to incentivize them and pay them more and more and more and more to even be engaged in work. They may be reckless, sorry about these words, but they begin with R, reckless in that they're just not totally engaged, so they make mistakes they didn't intend to make. They may have risky behaviors, such as substance abuse, or they may be at risk for suicide or suicidal ideation. They may be impulsive. And then workarounds, they may be this system's too complicated. I'm going to use a little bit of deceit to work around this complex system so that I can just get stuff done. And then you don't really know what's going on in your organization. Or they may be re-engagers versus disengagers, where they just are checked out. Oh, we're going to go back to this other one. So why do we care? So here you see very linear dose effect between burnout and whether or not you're professionally fulfilled, whether your career is as you expected it to be, cognitive dissonance, whether or not you're going to promote this practice, whether or not you're going to promote the care here, whether or not you maintain work-life balance, whether or not you're going to be retained at your institution. So we care. And if you leave your institution, you can see the turnover costs of just having your vacancy, having to recruit somebody, get them back up to par, can be $1 million per physician, 800 to 1.5 million, 800,000, or as Dr. Hahn estimated here, the amount per year for contributing to burnout per doc. So we really care about this. Any organization would be like, okay, this is serious. And you don't know cause and effect. So sometimes, one is affecting the other here because this is a cross-sectional observational snapshot. but it is circular and you do need to address it from every direction. So then what do we do now that we see this is very serious? We see the prevalence of burnout is more than half of our workforce. We see that it is undermining our mission itself, and it's dose related so clearly. So what are we going to do to address that? So we're going to assess our workforce, in this case, our physicians, and we're going to find out how well are they, those wellness metrics we just looked at, and then we're going to correlate it with some of those factors in the model. Here you can see Brian Bowman's right here. You can see his beautiful three-domain model here of culture and climate, where you're looking at those relationships between leadership, value alignment, teamwork, collegiality, how you fit in, be, and belong, and the practice efficiency, the hustle and hassle factors of your workday workload and your latitude of control, being able to match the resources with your demands and your latitude of control to be able to live up to the expectations. And then down there in the blue is resilience and your work-life balance, your self-care. Should you have work-life balance, I'm sure you know how to use it for your hobbies and your socializing and your family and your exercise and your nutrition and your backyard barbecues and everything else. So we'd like you to be able to do that. And so what we can do is we can find the prevalence of those drivers, and we can also find the correlations with our wellness metrics we're looking to improve. And we can keep working on that, and we can do it in an organized way so that organizational stakeholders and CEOs don't have to worry about physicians having voice and agency. They can actually be glad that they have the input. So when we think about creating our culture, collegiality, and community, I'd say when we get to collaborating, like what can we do with occupational health? What can we do with psychiatry? What can we do with each other? The number one thing we can do is stick together. Stick together and make room for one another and know that this is a big job and we all have something to contribute to it. And we're going to get to talking about that. But the first thing you're going to find out is even though you may say, oh, they don't have voice and agency latitude of control to be able to be optimal at their job, or there needs to be a process to collaborate with the other stakeholders, like we talked about with CMS and Medicare, Medicaid, quality, patient experience, and things of like, how do we all together float all boats and help one another? The first thing you're going to notice when you first start measuring these things is people came out of the woodwork because we were one of the first organizations to measure that burnout, is saying, yep, that's me, that's how I feel. So people started flooding us with feeling permission and feeling okay and feeling safe to say that they had that experience. So the first thing we had to do was get our safety net underneath us. We had to inventory what we had from all of our resources across the organization to make sure that we had something to be able to offer people who are distressed, who said they were burned out, who might be suicidal, who might be at risk of quitting, or those R factors, and needed to unpack that. And so the Human Resources, for example, has the EAP program. And we're going to come back to that kind of example, I think, in our discussion, because one thing wellness did for the EAP program is it used to be something that unit leaders might send their troubled folks to the EAP to get help with why they're struggling at work. But I think right now, today, and I think the wellness movement was a big part of that, is making it for the workers themselves that they could initiate that and they could go unpack things and they could have a place that was off the record, not in their medical record, not billed to their insurance, was a healthcare professional that they could go see, a mental health professional, And they could start to unpack things, not to get diagnosed, not to have a record, but just to say, this is what's going on, and have 6 free sessions and say, what can I do about that? The wellness movement went on to add peer support to that because it noticed that there was, for some people who do, say, operations, who might have a death on the table, for example, we found that those people um, weren't ready for that necessarily. They're now aware that some of our peer support is to prepare for them not to be shocked by hearing those things, because sometimes they might accidentally say, oh, maybe you shouldn't be a surgeon. Maybe this is not your line of work, when it might not have been an error. It might have been a very critically ill person they were trying to save, or it could be an error, but we were finding that there were some secondary injuries. But even now, EAP has improved because of our collaboration, the value of collaboration, that people know that that was something that was happening to people. That's because we got together and shared this experience. So there's peer support. We also trained people in how to be a peer supporter in question, persuade, refer for suicidal ideation, or suicidal. If we were worried about a colleague at all, we wouldn't turn away. We're prepared. We can ask our colleague, how you doing? And know what to do if they needed us to help them navigate help. I'm a certified coach. Many of our folks at Yale New Haven Health are certified coaches, and I find this amazing. I love to see colleagues have a chance to just decompress, unpack what they're going through. They often discover that, hey, these are normal feelings, and then to figure out what they want to do with those feelings. Our collegiality groups and our peer supporters, and we'll come back to our pros for peers as we talk about collaboration. So when we do our surveys, we find that every work unit is different. It's not the same, and you can't assume you know what it means. For example, this work unit has a EHR hassle score that's quite high. And you might think, oh, I know what that means. But you don't know what that means until you ask the work unit. And they will say that EHR scores because I'm treating people by in-basket because I don't have enough rooms to get them here in person. So I'm managing them by phone calls and the EHR. And that there aren't enough rooms, so we can't stagger our appointments, so I can't leave on time. We don't have team-based share the care because, and so I'm responding to all these routine labs that is adjustment to their meds, even though I wrote it in my note, what's going to happen. I have to order all those routine labs and routine med refills because we don't have, which is really adding to the cognitive load. And they feel like they have less support than other richer specialties. And then so once you know this, if you use the Joy in Medicine EHR metrics, you can follow the trends with your digital health people using these metrics. You can go to evidence-based remedies in the literature here, which we've outlined here. And there's a different stakeholder for each one of these issues, whether it's your digital experience, telehealth for rooming things, facilities, if nursing governance would allow less restrict computer physician order entry and allow templated orders, or the pharmacist helping with pre-approvals because this specialty has a lot of injectables, for example. So you don't really know until you talk to them, and that EHR metric can be very different for every specialty. So as we gather this information. And if you were to do one demonstration with this particular specialty, you can then show what works, doesn't work, and ramp it up because it's a lot of work to coordinate all these people. The other thing you find from the surveys is you can find positive deviance. Here in this particular unit, you find like these are all the same specialty, but they're at different hospitals. They're having very different experiences. And one of them is having a particularly good experience, and especially in the EHR space. Now, if you talk to enough people and you systematically get their interpretation, you'll find out I know exactly why. We have Dr. So-and-so, he's an informaticist, and he did these things for us. Oh, cool. Maybe we can scale that up in these other places. So as you then take your wellness scores and each unit, you can see, for example, J here at the top is green across all of these different domains. In this particular case, the survey is measuring teamwork, values, alignment with the organization, efficiency of practice in the environment, of which Brian Bowman is the author of this one. It's wonderful. And satisfaction with the EHR, negative impact on work relationships, sleep impairment, and self-valuation. So each of these have a lot of different interventions that have been made across the country to address these. Each of these have different stakeholders. These might be efficiency of practice, might be your clinical operations people. Your EHR might be your digital optimization people. The impact on work relationships might have to do with HR and flexible, the option of any flexible scheduling or part-time work, or it may have to do, there are any number of things that you can do for each of these. We did a pros for peers with our sleep medicine people, which I thought was so fun and so awesome, because you have people across your whole organization that are experts. And so we reached out to them. We did a sleep challenge. We made a sleep recipe. We did a sleep survey. We found that people didn't live according to their attitudes and values and all the bad habits we do. And then we can make that known. People can become aware of it themselves and make that known. So this is an example of how people collaborate together when we get these scores. The other thing you can do with these scores is now that you see these, you can be transparent so that Jay can say, Jay, you're not going to get the teamwork intervention because we're going to start here. And N might not be ready because they may be too resistant. So your easy to intervene people might be these other ones, R, K, B, A, C, for example. But it gives you a way to communicate that, hey, there's an order to this. It's fair. Everybody gets one vote in the survey. Everybody's voice counts equally, whether you're introvert or extrovert, or no matter who you are, your voice is equal and you get a say. And then the resources are allocated in a fair, just, reasonable way that people can get behind and trust. And then you might use this for strategy. For example, we're using EHR as the example here. It can be any driver. You can see these EHR drivers, their prevalence. And before, when I showed you the outcomes, would you get your care here? Are you professionally fulfilled? Do you keep work-life balance? Are you going to be retained here? You can then tailor your strategy to what you're trying to do. Oh, we've got to keep these neurosurgeons at that hospital. We cannot lose that neurosurgeon. And you might see a signal, or you might say, oh, that hospital up the road is trying to recruit our hospitalists. So what we need to do to keep them, for example. And then you need a way to bridge that communication between the clinical value alignment with the business side. So instead of our clinicians saying, where can I get $1,000? I need to do this or that. You have a way to say, I need $1,000 because I have a situation with this magnitude and urgency. You can use your input from your survey to do that. It affects quality, access, cost, the patient experience, and professional well-being, and it affects the academic mission. Here's my actionable plan, managed simply, and here's what I think your return on investment is going to be if you invest in this thing. And then they can say, ooh, that does sound good. And here's a thought. not only here's $1,000, here's $5,000. Happens like that, right? And then when you think about wellness-informed leadership, teamwork, and belonging, we're looking for ways that people feel seen, heard, valued, supported, and developed so they can be really masterful professional superstars in their work, feel professionally fulfilled, feel engaged, feel like they're growing personally, professionally, and in the organization. And this is Tate Shanafeld's leadership metric, for example, that measures these things we do have on our survey. And then you think beyond this too, what does it mean? When do you need command and control, hierarchical, bureaucratic leadership? There are circumstances when you need that. When are the circumstances when you need distributive, collaborative style of leadership? What does it mean to be a transformational or servant leader? And why would that be helpful under these circumstances, for example? And then as we're coming toward the end here, now we're getting to the institutional part, and we're going to get to organizational stakeholder collaboration specifically, is that as you move, and this is again one of Shanafeld's how you might think of moving through this system. In the turquoise here, you can think about where your organization is. They're aware of it. They understand the driver's dimensions. They know how to make the business case. They understand the impact on the quadruple aim or the mission of this organization. And this is integrated into key operational decisions. And then how do you operationalize it? Do you have a wellness committee where people have voice and agency and are moving things forward together and collaboratively? Do you do a survey? Do you act on the drivers? Do you monitor the progress? Do you, are you funded to do this? Do you measure the effectiveness of those interventions? And is it part of the strategic investment overall of what you're going to do with your findings? And then having voice, making sure that they have input, you got to close it. So like, we are in receipt of your input. Here's how we're incorporating it into digital optimization. We are in receipt of your input. Here's how we're incorporating it into clinical operations. We are in receipt of your input. Here's what we're doing to get you out in time for more work-life balance, for example. And then are leaders trained to be able to do this at every level to create a culture of wellness? So who owns wellness? No one and everyone. And this is where we're going to start our conversation. And when we come to occupational health, like when I started this presentation, I told you how I came into the space. I'm a systems thinker. I went to health services research and organizational science, and you probably went into occupational health because of your affinity toward these types of things as well. And like, we're all reshaping. So I said I'd come back to the EAP of how we started thinking about EAP differently, that it isn't where you send people who are having trouble at work to be work, it is that too. You can go and say, why am I having trouble at work? I got a lot going on at home and this and that, and you get some relief, but it doesn't have, it's not, we can start having a feeling like when we're in compliance with some of the things that occupational health also keeps us in compliance, is also changing that lens, that paradigm, that it's in service to the people, not just the organization or the patients, of how we create that kind of white glove experience. And then there's so many things too, as I get to hang out with Dr. Santiago and go to the conferences and see all the cool things on ergonomics and environmental medicine, which is so hot right now and is so important in this area. And then also thinking about all of the healthcare workers and professionals that go through your office, like all of them, pretty much, when say flu shot being mandatory, I think this is a marvelous opportunity to collaborate also with chief wellness officers to say, hey, how about with the flu shot? Everybody who comes through says, hey, go check out our peer supporter. And we do something like Mayo Clinic did with their finance office when everybody goes through there. Every person gets a chance to say, hey, did you know about all these things we have to support you? Which one do you want to talk about? And then you get a chance to introduce them to that. And then if they want to speak to someone more in depth or they're stressed out, which, when we do our one-on-one check-ins, about 10-15% are going to go on to get free 6 sessions, and then like 1 to 2% of those people are going to go on for more care beyond that. You're going to catch those at those intersections, for example. So there's so much more occupational health can do in the space, and I think this is a great time to have a conversation about all the stakeholders. The one thing is that we all have a lot of work to do collaboratively, and there's room for everyone, and we need to make space for one another and think like, okay, what part do you do? All right, you keep doing that. I'm going to send them to you, and I'll make space in my space. You make space in your space. Let's lift all these boats. Let's make together. Let's be greater. And then also, anyone in occupational health who wants to be a chief wellness officer, there's a pathway, just like I took a pathway to be part of this community and to learn from this community and see how it's evolving and share the models and share the vocabulary and share the work. Of course, that's another way to work your way into this space from your space and become chief wellness officers, for example. As a hospitalist, like that's another perspective. Oh, a hospitalist sees what's going on with primary care, what's coming from the ER, what's going from the ICU and all the consultants, and then what's difficult about the coordination and collaboration with care. Yeah, that's a unique perspective. It's helped me, but it isn't who I am in this work as a chief wellness officer. As a chief wellness officer, I listen to my constituents and I represent them and not necessarily my point of view. So let's see, I think that's, so we're strive to thrive at work and home. And let's discuss. And also, I'm going to take the slides down, but fuel your day with gas, gratitude, awe, and savor for a happy day. Pass it on. All right, I'm going to take these slides down, Romero, so we can
Yes.
talk.
Thank you. Thank you so much, Dr. Olson. That was wonderful. I look forward to this next phase of us discussing these important aspects. So
Yes,
welcome.
I'm going to ask some tough questions.
I have a question, Susan, here.
Yes. Hi, Susan.
Christine, I was wondering, has there been any evaluation of the burnout issue in relationship to the expertise the person has with regards to use of computers? And that may be a shocking question for our youngsters who are genetically, easily able to handle computers, but I'm wondering for either our older professionals or those who are less expert in computers, if that has been looked at, and if so, might there be an idea that maybe enhancing computer expertise and really emphasizing that would make life so much better as it relates to using the EHRs?
Yeah, so that's a mixed bag question. Yes, it has been looked at. So generally, proficiency with the EHR is not a key driver in correlation with the wellness metrics, but it's mixed in that people who have participated in highly effective to become more efficient, that's geared specifically toward them, they give those things high reviews. And I also would say that the EHR metrics are not always the direct driver of the unwellness, because it might not be have a high correlation, and yet the time on the EHR might be affecting your work-life balance, and then that is highly correlated. So it's a little bit, the model is a little, needs more modeling, but it seems like not strongly, and yet if it's a well-designed program, they're valued. The other thing that Kaiser Permanente Medical Group Southern California did, they used to do retreats every 2 years with sections and departments, and part of the weekend retreat of, it was collegiality and community building, but they also built templates to make their life easier and better. So those also were popular.
Thank you.
Great question.
I'll jump into the silence. This is David Diamond. Can you hear me?
Yes.
Yes.
Okay. I came on to a little late into your presentation, so I hope this doesn't you didn't already answer this, but this is your slides, your metrics, your graphs and charts. They're rather complicated.
Okay.
There's a lot going on there. I was taught, and I was a chief of medicine, and I had a staff of 30, ran a clinic where there were 300 people. I was taught a very simple rule, which was called walk around management. I would simply go around and sit and talk with everyone and say, how's it going? And what can I do? What can the organization do to make your job more efficient, more effective, whatever, and listen. And, that would generate ideas, and then we would operationalize them. Creating a huge data set with metrics and to focus, when you do surveys, of course, you don't get full responses. You get some biases. And if it's more complicated questionnaire, you can't, it's not as solid as kind of that direct speak to someone. And of course, you need organization at the top that's interested in having clinicians be happy and avoid burnout, and not just maximize income, throughput, or Press-Ganey scores on the basis of patients. We got a lot of Press-Ganey data. We didn't, and it was hard to know what to do with it.
Yeah, you're getting at you're essentially hitting into value aligning, and you're talking about two ways of getting at that too. Absolutely value aligning workarounds. One, people say attention, a leader's attention shows that you really care, for one thing. And the fact that they're listening rounds also gets to value aligning, feeling cared for, where people feel seen, heard, valued, and supported. Absolutely. That is probably one of the most effective interventions that you could do. I totally agree with you. When you talk about, overseeing 300 people, maybe that's still doable, but earlier on in the presentation, we talked about how we're getting into larger and larger healthcare organizations. So I survey 8,500 medical staff. That's just the medical staff. And the nurses are probably 5 times that, and then across 5 hospitals. So if you are organizing where your resources are going to go, you may have known evidence-based interventions. Your leadership intervention would certainly include, hey, if everybody could get out there and do some leadership rounds, that would be wonderful and effective. That would be part of that, letting people know what the evidence of that is. And an experience like yours, having people come give testimonials of how effective that has been, like with your experience, for example. But then when it comes to all 5 hospitals and systems getting bigger and bigger and bigger, you also have to have a way to coordinate it. And sometimes it's too often the squeaky wheels who get the grease. And when you have all those people, you need a chance for people who otherwise aren't usually heard to be heard.
Thank you.
Thank you for the excellent question.
Yeah, one other thought, one other method. I don't know if you've heard of Ballant or Swartz rounds or those kind of group conferences where there is sharing not directed at what the care was about, but how it felt to deliver that care. And these can be routine or problematic cases. And that was, people usually left those meetings feeling more connected to each other, I think.
Absolutely. I put Dr. Diamond here as a plant to say all the points all the great interventions. Yes, you're absolutely right. The Valiant groups or the collegiality, commensality groups, and those like Colin West with Mayo's Compass groups and our True North groups, and they are an opportunity to get together and talk about like who you are as a person and your experience in delivering healthcare. And Schwartz rounds kind of even more at the bigger kind of town hall level. Absolutely. Anything that builds collegiality and community and a care for one another really makes everything a lot easier and more collaborative. So thank you for mentioning those. I didn't mention a lot of interventional strategies, but absolutely anything that gets us more connected and collaborative. And we're probably headed into still some tough times with things that are happening in healthcare. So more than ever, I think I'm glad you brought that up because I think the key is stick together. Key ingredient to quality is love. I'm going to say the hokey thing again.
Hi, this is Sandy Stratford, and thank you for this presentation. I had a question. How does the neurodiverse workforce fit in here?
Yeah. Well, the basic metrics, for example, if you're talking about surveys, well, people will give their experience and then we don't always have your identifiers, but people will write in the comments. So for example, when I ask about their sense of belonging and inclusion, wow, that's rich material. And neurodivergent colleagues will write in what their experience is. So we can often, the qualitative aspects of the survey really very rich. We always get at least 2,000 comments. And then if we ask specific things, that's where people will tell us about their experience as far as belonging and being included. People will say, hey, it's not just as narrow as we define it, or, people feel left out because it's stereotyped of what it means to be included. And they will really bring that up and they will talk about how they want to be recognized. And then we cascade that up to chief leadership and also across the organization through that input.
Thank you.
I'll mention too, we didn't talk about when it comes to rest and recharge and those things, I didn't go through like basic kind of healthcare things like physical, emotional, social, environmental, spiritual or meaning, intellectual kind of well-being things too, because that's another way to think through those things.
If I may ask one final question, I know we're getting really close to noon here. Just to ask you, Dr. Olson, like in terms of there's so many groups out there that, in terms of the chief well-being officers, for example, there's the American Association of Physician Leadership, and then the AMA has the American Conference of Physician Health and so forth like that. In terms of the spirit of knowing that community of which I know you're part of that, chief well-being officer community, and the way I think of it is that for us to really standardize the collaboration is making sure that we know, what that group is, or what type of venues does the group convene at to get together and talk about things. How would you describe the way that these interface, like the American Conference of Physician Health and say AAPL that tries to talk about physician leadership and so forth?
Yeah, so thanks for bringing that up because everyone is welcome. Please join us. The American Conference of Physician Health happens every other year, hosted by the American Medical Association, Mayo, and Stanford. And the International Conference for Physician Health happens every other year and rotates between the Americans, the British, and the Canadians. And then you also get people from all over the world. We get quite a few Australians as well. And this is the place where it's probably the premier conference for where the chief wellness officers and this type of wellness work that's happening in healthcare happens, especially for medical staff. So please come and join us, and also think about putting your entries in your abstracts. This year will be in Boston in September, I think September 11th through something. So think about joining us. And then the next year will be, I believe, hosted by the British. So we'll go where the British Medical Association will be hosting that. And so that's one way. Also, out of this work that the AMA is doing through professional satisfaction comes the Joy in Medicine Recognition Program. So take a look at that, of what their kind of criteria are. That'll be helpful. There's the Chief Wellness course. Stanford runs both the Chief Wellness training courses and the Director's course for those running wellness for the specialties. Many of the specialties also have in their professional societies, also have a wellness committee usually in their professional societies. And that's really the idea, to mobilize as many of us as we can and to stick together. And so whatever occupational health has bubbling up that you are all attending to, feel free to reach out to the platform for the clinician or the chief wellness officer to be able to get more eyes on your work. And also think about yourselves if you are thinking about becoming chief wellness officers as well. Yeah.
Wonderful. All right. Thank you so much, Dr. Olson. Okay, I know we're just a few minutes over 1 p.m. Eastern. Thank you so much, really, Kristine, for such a wonderful presentation and for sharing the overview and your perspective. We couldn't have asked for a better person to lead this conversation. And this is just the beginning with more to come. So
thank you for inviting me. Thanks for everyone who showed up here today. I really appreciate that.